introduction, if that's okay. Again, and that
Sure.
was my time to start the webinar alarm. So, but my name is October Boyles. I work at Notes. I'm the Chief Clinical Officer, and we are here today with Don Morrison, or Donald. He is a licensed clinical social worker. He has over 17 years of experience in the mental health field, and he's worked in a school out-based program or school-based program as an outpatient therapist. He's been a lecturer at UNC Charlotte at the School of Social Work. He has tons of management experience as a social work supervisor for a very large adult inpatient unit and in Charlotte, by the way.
Yes.
And he also performs clinical supervision for provisionally licensed therapists, and he owns his own practice in Mooresville, North Carolina. So, Don, I'm going to let you go ahead and take it away.
Absolutely. Thank you, Eve, for that generous, kind welcome. And certainly it's good to be with all of you guys today. Welcome from everywhere, everybody here. Thank you for being here today. And October and I were just talking. We were saying too about how important it is to keep it real with conversations about mental health. And that is my approach professionally, especially with therapy, like keeping things real, being genuine, being authentic, and just having a conversation. So, when I do webinars, I want it to feel like we're having a conversation, and I do want the dialogue to be there too. So, I mean, certainly we're going to save a little bit of time at the end for questions and such. And I do recognize that within, Eve, how much time do we have? Like 45 minutes for the lecture around that time?
Mm-hmm.
I know that with this, seriously, we could probably do an entire course at a university on the biopsychosocial assessment and all the different aspects of it. So I'm going to try to move things along kind of quickly here so we can hit some of the highlights and definitely get to some of the meat and potatoes of what the biopsychosocial assessment is about. But please feel free as we're going through to ask questions, and we'll try to address questions as they happen to, if you have anything that's just you want spoken to at that moment. So also too, as with most that's a lot of people nowadays, I am working from home. So if you guys hear any squeaking or any little barking or any drama in the background, that's my dramatic little drama queen, Lola. She's my Shih Tzu. We just got her last week. So I mean, if she's making any noises in the background, that is indeed her, and she's my mascot for today and doing this webinar. So this is just where we are right now in working from home. So today we're going to talk about the biopsychosocial assessment and what that means, looking at some of the history, just a little bit. I want to breeze through some of the history of DSM diagnosis and assessment just for a brief moment. We'll look at what it means to, what a biopsychosocial assessment means and why is it important, why do we use it, and we'll look at some specific case examples and especially how ICANN Notes addresses those needs within their electronic medical record. So let's start a little bit with some of the history of mental health diagnosis and assessment even. We did start pretty early with looking at diagnosis. In 400 BC, Hippocrates formulated this theory that certain personality types are related to the amount of body humors that we have, such as blood, black bile, yellow bile, and phlegm. You guys have probably seen this in your DSM-5 or mental health history courses before, where the sanguine personality, for example, is very cheerful and optimistic. The melancholic personality is depressed, and that results from too much bile in the body. The choleric personality, hot-tempered because there's too much yellow bile. And the phlegmatic personality leads to apathy and sluggishness because of too much phlegm. Now, I think that even though this was in 400 BC, I think now it's proven, even as we're looking at assessment through a biopsychosocial lens, we do know the importance of biology and how it does impact our clients and our mental health, and how all of that is connected through this very holistic approach. So I do think that folks were onto something here. And especially too with the Greeks, when they were, I didn't include this, but especially with the Greeks, I'd love your feedback on this, where they initially considered an aspect of diagnosis with this so-called wandering uterus that was the cause for pathology in female clients. I'd love your thoughts on that, of the wandering uterus, and if you've ever heard of the wandering uterus in any of your mental health history courses. So please hit us up in the chat if you indeed have. I find that very interesting. I also find very interesting that in 1840, the U.S. Census classified all mental disorders as idiocy. And I would like to think we've certainly grown a lot more since then. We certainly don't use terms like idiocy or idiots any longer. And we certainly look at our clients more of a person-centered, strength-based perspective now. But this is, I think, part of the picture of what we were seeing in this development of mental health diagnosis. In 1896, the German psychiatrist Emil Kraepelin established 3 subtypes of dementia praecox, which was later defined as schizophrenia. And so I think this was really land-breaking when we really started looking at some of the different subtypes of schizophrenia. This laid some of the groundwork for some of the subtypes of schizophrenia that we saw, even up to DSM-4 text revision. Any of you older clinicians in here who've been doing this for a little while, you may be familiar with the DSM-4 text revision. DSM-5 has done away with the subtypes of schizophrenia, but I think this gives us a helpful perspective on where we were with diagnosis at the time. In 1911, Swiss psychiatrist Eugene Bleuler developed the term schizophrenia from the Greek word meaning schizo, meaning split, and phrene, which means mind. And this new term replaced dementia praecox and madness and lunacy, which we no longer use those terms either in the mental health field, as you guys well know. So in the early 20th century, and Eve, will you click the slide for us, please? Thank you. In the early 20th century, the World Health Organization, the WHO, which you guys I know are familiar with, they began work on the International Classification of Diseases, the ICD. 1917, the American Psychiatric Association began work on classification of mental disorders that was added to the ICD-6. And as you guys know, when it comes to assessment, we do have to assess, we do have to diagnose our clients with diagnoses from the ICD-10, which we'll speak more to that in just a little bit too. So in 1952, the very first DSM was published, and it was pretty much, I think, if we're making a comparison, and I hope I'm not minimizing its impact here because it was huge, but if we're making a comparison, it literally was almost like a pamphlet size. I wish I had a visual representation of it I could show you, but it literally seemed to me to be a pamphlet size book here. In 1968, the DSM-2 linked ICD, we changed from reaction to disorder. In 80, the DSM-3 introduced the multi-axial classification system, which as a little bit of an old school mental health clinician, I do kind of miss that. I love your feedback on that. Anybody in the house today that misses the DSM-3 text revision of the multi-axial classification system. Also, revision of the DSM-3 in 1994. We saw the DSM-4 in 2001. The DSM-4 text revision was published. And in 2013, after a long gestation period, the DSM-5 was indeed published. And I think it was, I believe the American Psychiatric Association spent around $14 million on the development of the DSM-5. And rightfully so. This is a very important, as we know, an important manual which helps guide our diagnosis. And it really pretty interesting fun fact too. Does anybody here today know why that the American Psychiatric Association changed from using Roman numerals to describe their different versions of DSM, and they changed the alphanumeric version? Anybody at all, right offhand? I thought just a little bit of a fun fact. I think that we changed it because the American Psychiatric Association is actually planning on releasing future updates. I have not heard anything lately on where we are with releasing any updates, but the American Psychiatric Association plans to release updates as they did with the text revision of DSM-3 and DSM-4. They're planning on releasing text revisions, and they plan to do it using the number system where we see let's call it text revision for instance, where we see text revision 5.1, text revision 5.2. So that's why they are using the traditional numeric system there. in case you guys were interested. So now that's a little bit of the history to this. Now getting more into the meat and potatoes of the biopsychosocial assessment here. This is, I think, in my opinion, one of the most important things as clinicians that we can do. We are meeting our clients at very difficult points in their lives, and I do think that it is as vitally important that we get an assessment that is accurate and really portrays what is going on with that client at that particular moment in time. So oftentimes too, the biopsychosocial assessment is sometimes, not always, interchangeably used with the concept of this competency-based assessment model. I am a clinical social worker, and I think from the social work perspective, we always look at our clients' competency. We look at their ability to do things. We really view them from a strengths perspective and an ecological perspective, which we will absolutely get to in just a little bit too. But the more specific definition of assessment is we are in this process of determining, well, what's going on with this client? What brings them here to the office today? What is causing them distress? What are the situations that's contributing to these issues? What are the different types of personalities and different types of systems that they interact with that would be contributing to some of these issues? And really trying to get down to the heart of the matter here. We're trying to understand their concerns. We're trying to understand what's causing it, and what can be changed to help them or to minimize or to resolve some of these issues. I think that we as clinicians are generally considered to be change agents, and I think that that is part of what we do in working in mental health, is that we help our clients get to a more positive space in their lives. So the competency-based assessment, or the biopsychosocial assessment, reviews and understands their individual's past, so we can interpret their presenting issues and concerns. I think that especially when we're looking at assessment, I think it's so vitally important that we look at our client's history. Certainly, there's this old saying that history is a good indicator of future behavior, which this is indeed why we assess for that, so we can try to determine how best to help our clients move forward here. And in this assessment model, as we know, and we'll break this down a little bit more here in just a little bit, we're looking at all the processes that are affecting our clients' lives. We're the biological, the psychological, and social systems, i.e. the biopsychosocial framework that is really impacting our clients' overall level of functioning. And Eve, would you go to the next slide, please? All right, so a competency-based assessment, or the biopsychosocial assessment, really utilizes the ecological perspective, where we're drawn to attention how the client interacts with their environment. And from a biological standpoint, we as clinicians are always assessing for what sort of physical diagnoses are our clients dealing with right now, what sort of metabolic disorders, any kind of immune or stress responses, any genetic vulnerability here that's going on with our clients. We do know that there is a genetic component to mental illness. We do know that mental illness does run in families. There's a high genetic component for mental illnesses such as schizophrenia and bipolar disorder especially, that we have to be mindful of. And trying to get that history from the client is so very important. And also trying to recognize too, from a biological perspective too, what are any kind of issues with comorbidity here? Comorbidity means, as you know, co-occurring type of disorders that we need to be aware of. So we recognize that our clients from a biological perspective certainly deal with multiple physical illnesses, so diabetes, heart disease, cancer, HIV, seasonal allergies, et cetera, that we do have to be aware of, because those biological issues do affect the psychological and mental health and social and environmental issues as well. So the psychological piece, there's so many different aspects to this as well, where we see, issues with self-esteem, their attitudes and beliefs toward themselves and other situations, managing their emotions too, and becoming more aware and mindful of their feelings. We'll talk about the mental status examination in just a little bit too, where we address some of that as well with mood and affect. So we'll certainly get to that. But also too, from a psychological perspective, how our client perceives things? How do they perceive themselves? How do they perceive their reality? And what is their temperament? What is their mood like? How do they interact with folks from a social perspective? And as you'll hear, and I know you clinicians here with me today, you know all about coping skills and helping our clients figure out how to address some of these issues through some very specific coping mechanisms that can be very helpful with helping them move forward with their lives here. But also too, again, from an ecological perspective with the social piece, we have to be aware of what's going on with our clients from a social and environmental standpoint, especially with their peers, how the client interacts with home, school, work, and really their socioeconomic status, their culture, and any other family circumstances that might be going on right now that will naturally impact their overall level of functioning and their mental health. I've always said this, and I'm sure you guys are mindful of this as well. So I don't want this to come across as lecturing. I don't want any of it to come across as lecturing today, but I will say from my personal experience, I think it's so very important that we examine a lot of these social and environmental factors that are going on with our clients, because as you know, we've certainly been dealing with a life-threatening pandemic here for the last year and a half, especially, but before that even, we have to be very mindful about what's going on with our clients when they are at home. When they leave our office, what is going on there at home? You know, I use the example when I was working as a school-based clinician in a Title I elementary school here in North Carolina. You know, I would have literally some of the best sessions in the world with some of my kids that I was working with. And then they would often go home when they left our session, went back to class, and would go home. There would be difficulties at home, such as keeping the lights on, keeping food on the table, you know, making sure that they had clothes, making sure that they had heat or air conditioning, et cetera, et cetera, et cetera. I think sometimes we as clinicians, we're not always mindful of that. And, you know, I think it's important to recognize that our clients do not live in a vacuum, and that when they do leave our offices, when they do leave our video chats and telephone calls, they oftentimes do find themselves in very stressful social and environmental situations. So we as clinicians have to do a great job with assessing for that and trying to figure out how to ameliorate some of those issues. And we'll absolutely get to some of that in just a little bit as well. So Eve, would you give us the next slide, please? Also too, hang on, let me take a water break here. Also too, the ecological perspective also looks at, I'm not going to spend a lot of time talking about this because, again, I want to get to the meat and potatoes of the assessment, but the ecological perspective also takes into account how the person interacts with their environment and how they adapt to their environment and how that person fits into their environment. So as we know, life stressors, difficult social, developmental transitions, traumatic life events, again, things like keeping food on the table and keeping the lights on. These are all the things that disturb their fit with their environment. And also too, as I know you clinicians do, we're always addressing stress and how life stressors impact anxiety, guilt, anger, helplessness, depression, etc. Everything is interconnected here. And as we just talked about too, with coping mechanisms, trying to find coping measures, trying to assess our client's competency, meaning that we're assessing for their capabilities. We're assessing for their capacity to be able to carry out some of these things that we're talking about here and to be able to express their feelings in a healthy way. And I think we as clinicians need to establish a healthy environment for them to be able to do that, a safe environment for them to be able to do that. And we'll absolutely talk about that in just a little bit as well. And Eve, can you switch to the next slide, please? And a little bit more about this, the competency-based assessment, the biopsychosocial assessment also incorporates some aspects of systems theory, which basically conceptualizes the world as being ever-changing and it's not fixed. We're always examining, again, how all of the various systems that interact with our clients impact their overall level of functioning. And we'll speak more to that. You've heard me say overall level of functioning numerous times already. We'll get to that a little bit when we look at the assessment piece as well. But again, from the biological, psychological, and social standpoint, we're looking at all the various complex interactions that these systems have with one another. And can we do next slide, please? So why do we even use the DSM-5 and the biopsychosocial assessment? Well, first of all, I think that it's common communication among clinicians. And I recognize, and thankfully so, our field is so diverse and so fantastic. We have numerous different professions that are working in the behavioral health field now. We have counselors, we have psychologists, we have social workers, we have psychiatrists, we have psychiatric nurse practitioners, PAs. Am I missing anybody? Y'all shout out to me if I missed anyone. But there's so many people working in the mental health field today that I think a comprehensive assessment really does help build that communication among clinicians. So regardless of your professional background, the assessment stays the same. There is that consistency, I think, that is very important. There is a certain expectation that we as clinicians be aware of the different terminology and the different types of ways that we communicate in the assessment. So I think the communication has certainly got to be there. I'll say, DSM-5, I'm certainly a fan of in many aspects, but again, I do miss the multi-axial format and the DSM-4 text revision where we had axes 1 through 5. Axis one being the focus of main clinical attention, your main mental health diagnoses. Axis 2 being personality disorders and intellectual disability. Back then it was referred to as mental retardation. You've got Axis 3, which are any of the medical conditions. Axis 4 would be any of the psychosocial stressors that our clients are dealing with. And Axis 5 was the GAF score, which was the global assessment of functioning score, where we assigned a numeric value to our clients' overall level of functioning. Now, I don't know if there's any of you guys that missed the DSM-4 text revision multi-axial format. I certainly do, because literally no matter who you were as a clinician, regardless of your professional background, you can look at that multi-axial format and you can see that it's just in that brief snapshot of what's going on with that client. And I still kind of sort of do something like that related to DSM-5, and we'll certainly talk about that in a little bit too. But I think we use DSM because of communication among clinicians especially, but also to research. DSM has proven to be a pretty helpful research tool where we found that some of the latest and greatest research has been published even in DSM. In the DSM-4 text revision, for example, there was numerous studies that were included on the study of borderline personality disorder, for example, and we found that personality disorder affected more male clients than we had initially thought, and we were seeing more and more as moving forward that was a disorder that was becoming more common in males, and that's just one example. So I think DSM does a good job with helping with research.
And Don, we threw up a poll on, do
Yes.
you prefer the DSM-4 or the DSM-5, just giving people an option. We just love,
yes,
we love to get feedback, and polls are really easy way to do it. So
absolutely. And I'll not spend so much time talking about DSM-4 because I know we're using DSM-5 right now, but certainly I do miss it. So, all right, and then I'm gonna be quiet about it. I'd love y'all's feedback on that. So please give us some honest feedback on that, no doubt.
We are getting some really good responses. So
yes.
The DSM-5 right now, it's about 72% that prefer the DSM-5, and about 27% DSM-4.
I see. Excellent. Well, thank you guys for sharing the feedback on that, no doubt. And certainly that is our main focus with DSM-5 because, hey, it's what we're using now, and bringing it to current, that's what's most important. But I'm just wistfully remembering the good old days, right? Anyway, thank you for your feedback on that, no doubt. And one of the biggest things here, I think, too, number 3, is insurance reimbursement. I know most of y'all, I would be surprised if no one had any experience ever with any insurance company, but with insurance reimbursement, we have to have an assessment and we have to have a diagnosis. And in order to get reimbursed, i.e., if we want to get paid, we have to have an assessment and we have to have a diagnosis and we do have to have a treatment plan and records of meetings, the meetings with our clients through our regular progress notes. So that is important because I don't know if any of you guys have experienced this ever, but if you've ever had to deal with any insurance agencies who require chargebacks and request you to pay the money back because you didn't have an assessment or a treatment plan signed or progress notes done within a timely fashion, that can be a very painful experience. So having to pay back can be very difficult. Working for an agency where they are required to pay back money that you were responsible for the paperwork that was missing. Yeah, that could make for some very difficult conversations. So let's please make sure that we have an assessment, and let's please make sure that we have a diagnostic code. And DSM-5 we know is ICD-10 diagnosis code, no doubt. We'll speak more to the diagnosis piece in just a second too. But also too, we use the assessment and DSM because of medical and pharmacological treatment planning, right? We know that, if we're going to diagnose our client with a certain type of diagnosis, then we do know that certain types of medicines really do respond well with treating those particular issues. Like, for instance, with someone living with schizophrenia, for example, we know that many of the antipsychotics and mood stabilizers are very helpful, and we wouldn't necessarily prescribe them any of the psychostimulants for ADHD, for example. And I know that's a weird example, but I think that assessment does help guide our medical and pharmacological treatment planning, as does the psychotherapeutic treatment planning. When we're looking at our assessment and our diagnosis and treatment plan, everything has to connect. You are going to be working on very specific time measured goals where it's related to the diagnosis. So your goal would have to match up with the type of diagnosis that you assign that client with the help of the biopsychosocial assessment. And we'll speak more to that in just a little bit too. And Eve, will you switch to the next slide, please? Now, getting into some of the nitty and the gritty of biopsychosocial assessing, questions to ask, and those type of things, these are just some of my general tips and recommendations that I think can be helpful when we are diagnosing our clients through the assessment. Remember, number one, I think remembering that a trait, which is like an enduring characteristic of an individual, or syndrome, which is like a cluster of different symptoms, it's not a mental disorder unless it involves significant distress and or impaired social functioning. So I know when I first started studying DSM, I was diagnosing myself. I don't know if you guys have done that before, but I was diagnosing myself and I was diagnosing my family and friends. It was a very interesting time as I was trying to learn all the different aspects of diagnosis. And I've inevitably had family and friends come to me and say that they need me to diagnose them with something. But I still say that just because we all may have traits of certain things, but that doesn't necessarily mean that we meet full criteria for that disorder. So let's please keep that in mind. Also, too, as you know, we have to consider any substance abuse issues, and also, too, if necessary, completing substance abuse assessments at that time. The Cage Aid, I think, is a great user-friendly example of that, which lots of very helpful check boxes where we are assessing for how long, what substance the client's been using, how long they've been using in that way, when was the first time they used, etc. So those type of assessments are so important with getting those details. And getting back to the biological piece, we do have to ask and assess our clients for any medical conditions and or any sociocultural factors that impact the client's lives. And I think DSM-5 it does so many things well. It especially does believe it or not, I was actually pleasantly surprised with this. If you guys have ever explored the DSM-5's cultural formulation interview, the CFI, it is a wonderful resource with asking very strengths-based, person-centered type of questions regarding our clients' culture and how their culture, it's impacting what's going on with them at that moment. And it's really a pretty awesome resource that I'm not so convinced is being used like it should. And can you guys give me some feedback? I don't know, Eve, can we do another poll by chance? Are you guys using anything from the cultural formulation interview when you are taking into account the social and cultural factors that are going on with your clients? And we'll speak more to the CFI in just a little bit too. I'll give you some specific examples of that, but it's just an invaluable resource. If there is any doubt, number 3, if there is any doubt about whether the patient or the client, whichever terminology you use, patient, client, consumer, meets criteria, severity and duration can be deciding factors. So as we know with DSM-5, we really have to, they really have they're wanting us to be as specific as we possibly can when we're formulating our diagnoses and our assessment. And so we always have to be mindful of how severe the symptoms are and how long that they've been occurring. So, and you guys know in terms of developing your diagnosis that those are such huge factors in that. And oftentimes we look at diagnosis as a continuum. Even if we're looking at depressive disorders, for example, we know we have everything from major depressive disorder to unspecified depressive disorder. So, you know, and DSM-5 again wants to steer away from the unspecifieds and be as specific as we possibly can, but also too that can lead to some complications when we are required by insurance to make to formulate a diagnosis and to complete the psychosocial assessment within what is it now, 60 to 90-minute window, and that can be very difficult with that. So while DSM-5 is saying we be as specific as we possibly can, I tend to lean more being more conservative with diagnosis, because this is your first meeting. And you know, you're only probably getting about 9% of what's going on with that client in that initial meeting. I think that I look at assessment as being this ongoing process. It is certainly like a living, breathing document, even when we continue to learn more about what's going on with our clients. Because I mean, unless you really develop that awesome rapport with your client, you're probably not getting all of the pertinent information that you need in that initial meeting. Please, when it
John,
comes to,
oh, sorry.
yes,
I just want to tell you the poll results. People in here are very honest. We absolutely love that, and so that 87% are saying no, they're not using that cultural formation interview. 13% are using it, and I did want to highlight that in iCanotes we have a lot of forms and assessments, and that is in fact one of them. So
yes,
that we
absolutely. And listen, I'm proud of you guys. Thank you for being honest about that. Seriously. And you know, I think because I think you can tell me if I'm wrong here, please, because I'm wrong all the time. But I think when it comes to when you hear me say cultural formulation interview, do you automatically think, oh my God, here's another form? So it's just another thing that we have to add on, right? And you don't. I would like to throw out there too. You don't necessarily have to think of it like this. I think that maybe just kind of cherry picking some of the questions that you like from the cultural formulation interview that maybe you can use for your assessments too. I think that could be helpful, but please don't feel like you have to complete the entire assessment because I believe it is 16 questions, I believe. And so, like I said, cherry pick some of those that you feel like would be most beneficial for your client. And we'll speak more to the cultural formulation interview in just a second too, I promise. But also number 4, please avoid premature closure when it comes to diagnosis. I don't know if this has happened with you guys. I've been guilty of this before, if we're being honest with each other today, that research has proven that clinicians tend to make a diagnosis in the first 3 to 5 minutes of meeting the client. And oftentimes I've been guilty too of when I first meet the client that I'm focusing on formulating a diagnosis and I'm not really mindful and paying attention to what's going on within the assessment. So let's please try to avoid diagnosing clients almost immediately, and let's stay present with them and let's listen to what it is that they have to say. And as conservative as you possibly can be, let's please be mindful with that too as you're developing your diagnosis, because as we know, diagnoses like schizophrenia and bipolar disorder, et cetera, they do carry a lot of weight and they do carry a lot of stigma. So we do have to be very mindful of not automatically diagnosing our clients within those first few minutes. And also too, if you guys could please, when it comes to educating your client, when it comes to educating their families and their support systems about what's going on with their mental health, please use plain descriptive language. Make it a collaborative process too, because I think that and again, I know I'm asking for more time here, and time is always a luxury that we don't always have, but I think that especially I saw how important the collaborative process was with family members when I was working on the adult inpatient unit that I was working at the behavioral health hospital in Charlotte here, where we found that was vitally important when it came to finding out what was going on with that patient before they were admitted to the hospital, and getting all of the necessary background that was so important to really help in our assessments, and help in figuring out their treatment plan and where we were going forward with everything. So the collaborative process, although I know it's a luxury nowadays, but I think it's just so vital in terms of getting such useful information from our clients' support systems and collateral supports here. And also too, please listen. We know all the clinical terms. We use it all the time in our documentation and assessments and such. And I know you guys are brilliant. You're fantastic. But please, 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 when it comes to talking with your clients, let's try to steer away from some of the jargon. Let's try to talk to clients kind of a little bit more down to earth, and let's just help to educate them, but let's not use all of the terms that they may not always be familiar with. And I love doctors. I think physicians are fantastic. If we have any physicians, any psychiatrists here on our presentation today, you guys are fantastic and wonderful, but sometimes I've heard from my own personal experience, you do kind of talk over the patient's head. So let's please, if we can, use some of that more down to earth language. That would be fantastic. All right, Eve, can you switch to the next slide, please? Now, how comfortable are we here today with our engagement skills? I want you guys to really ask yourself that, because I think that, and you get certainly, please feel free to disagree with me, but I truly do think that client engagement is so vitally important in terms of building that therapeutic rapport, that therapeutic alliance, as we call it, so they will feel comfortable in sharing things with you. And please give some feedback with any of the questions or any, as you will, please feel free to share your thoughts about that. I really do feel like client engagement is really like half the battle when it comes to assessment. If your client does not feel comfortable with you, if your client feels very guarded, if your client feels like your office space or wherever you're doing the biopsychosocial assessment does not feel comfortable, and if they perceive that you are stressed, or if they perceive that you're tired, or they perceive that you're got 12 million other things going on, as we often do, you guys, although your feelings are valid on that, with all of that busyness and all of the hard work that we have to put into mental health nowadays, let's please try to work hard at being mindful of our attending skills. Meaning that, we keep good eye contact. We have an open body language. We're not crossing our arms and closing ourselves off to our clients, and that we try to present in a very friendly, approachable manner. Nobody says you have to be friends with your clients. I'm certainly not saying that, but please, as you can, try to be friendly and try to be engaging with them, because I think you'll get more information from them that way. And I think that this will help give you more evidence and more criteria in terms of developing your diagnosis that can really help with the biopsychosocial assessment. No one likes to feel like they're being analyzed under a microscope, so let's please be mindful of that. And I know you guys see, we all see our own providers for whatever. And I always like to think about, whenever I'm working with my clients, whether it's with assessment or whether it's with any of our regular sessions, is that, if I needed some type of provider to do some type of assessment and intervention with me, that what kind of treatment would I expect and want? Let's please, if we can, keep that into perspective too. I think that could be helpful. And also too, I saw this so much on the inpatient unit where I would often hear providers referring to clients as, oh, she's borderline, or he's schizophrenic, or she's bipolar, or she's a, no, please, 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 let's steer away from this type of language. I know you guys have studied person-centered approaches and person-centered therapy, which I'm a big fan of. Carl Rogers is like just my idol. So if you guys know Carl Rogers at all, he developed this concept of unconditional positive regard for your clients, meaning that, hey, you know what, regardless of what was happening with your client, you still held them in high esteem. You still view them as a person who is struggling, but still a person that has value. So please, let's just be mindful of the type of language that we use with our clients. I don't know if you guys have ever heard this or heard, but you know, it's definitely, I think, a big issue because language really matters. Language matters. And please do not minimize the impact of the client's cultural considerations that are going on with them. We mentioned the DSM-5 cultural formulation interview a little bit ago. It is an excellent resource to assess how a client's culture impacts their functioning. And Eve, would you switch to the next slide, please? And pertaining to this, what we see in the westernized medical model, what we may consider to be mental illness, others may consider to be a very normative cultural response. And so we are kind of sort of getting into those culture-bound syndromes. I don't know if you guys have heard of those or not, any of the cultural considerations going on with our clients. There are numerous culture-bound syndromes that we, as clinicians, I think should be aware of. There's falling out, where we see some clients, if they're oftentimes in a religious space, where they oftentimes get so overwhelmed by having this religious experience that they pass out. We've got folks who feel like from various cultural backgrounds that feel like trance-like states or possession states are very culturally normative. And that we have to be mindful as clinicians here that what is culturally normative for them may be perceived as and diagnosed as a mental illness through the westernized medical model. And you can imagine, and if I'm generalizing, I apologize, but you can imagine that if you are in a psychiatric emergency room and your client starts talking about being possessed and having experiencing these various possession states, what's from DSM-5, what does it say? Okay, well, maybe this client's dealing with some sort of psychotic illness related to schizophrenia and such. And, that's not always the case. That's not always the case. So we do have to take the impact of culture. So it's such a vital part of what's going on with our clients. So these are just a few of the questions that we see in the cultural formulation interview, where one of them, these I think are kind of my top three here, where sometimes people have different ways of describing their issue or problem to their family, friends, or others in their community. How would you describe your problem to them? And sometimes aspects of people's background or identity can make their problem better or worse. And by background or identity, I mean, for example, the communities that you belong to, the languages you speak, where you or your family are from, your race or ethnic background, your gender or sexual orientation, or your faith or religion. For you, what are the most important aspects of your identity? And I think that, we do get this information throughout the biopsychosocial assessment. I think ICANN Notes does a great job with collecting that information. But, these are the important things that really do play such a huge role in our clients' lives. As we know, our culture impacts who we are as individuals and who we identify as individuals. And probably one of my favorites is often people look for help from other different sources, including different kinds of doctors, helpers, or healers. In the past, what kinds of treatment, help, advice, or healing have you sought for your problem or your issue? And please, give me some feedback too on what you guys think about the cultural formulation interview and some of those questions. And like I said, you'll find the cultural formulation interview in the appendix in the back of your DSM-5. So please feel free to explore that and figure out, what types of questions you would like to cherry pick to use with some of your clients. And it's about 1:45. So I know we still got a little bit more to go. Like, how are we doing with time here, do you think? October, can you hear me? October, are you there?
Can you hear me now? Sorry.
Oh, yes,
I feel
I
like
can
the
hear you now.
Verizon
Hey,
guy. Can you hear me
it's
now?
all good.
Yes. We only have a couple slides to go through, just kind of what you were going to go over as far as a sample assessment and what that would look like in IQ Notes. We do have some requests for SUD, and so I can go through. I'm happy to show the ASAM after
Yes.
we get the questions answered. And
Absolutely.
yeah, so are you ready for next slide? We go to, or
Absolutely.
we are
Yes.
here. Okay.
Yes. Absolutely. All right. This is the history of present illness, or the HPI, as it's often referred to. And this is where, again, we're trying to obtain some valuable history about what's going on with our client. Again, we know that there's a biological component to mental health and substance abuse issues. So, we do have to be aware of what's going on with our clients from a biological or even medical perspective. So their history of present illness. In this case, this client is 49 years old, a married female with depressive symptoms. She has problems that include economic, legal, housing issues, pending divorce, and loss of a pet. So I'm hearing thus far that with this client, there is a lot of loss. And there's a lot of grief and loss here, not just related to the loss of her pet, but also from the loss of her relationship and with her divorce. So therefore, we see this client dealing with feelings of sadness, guilt, worthlessness, isolation, decreased appetite, libido, crying spells, and irritability. This client also expressed suicidal ideation without intent, but she does have access to a firearm. So I'll tell you also too, in October, please feel free to jump in with this in terms of navigating ICANN. I will tell you this, one of the beautiful things about ICANN is that there are click boxes. You can click it, and it's fantastic, because I think that a lot of times, now I'm coming from the good old days, because I'm a little older. I'm coming from the good old days where we literally had to write out everything in our assessment. I don't know if there's any folks here today with me who had to write out their assessments, like literally write everything out in a paper chart in a hospital. So if you guys do remember any of that, please give me a shout out with that too. But literally, we had to write things out. And sometimes, unfortunately, we would use abbreviations that was a quick way to do it, but it led to some confusion too. So we are supposed to write everything out. We are supposed, instead of using AH for auditory hallucinations or SI for suicidal ideation, homicidal ideation, HI, we do have to write those out. And that's the beautiful thing about ICANN, is that you can click a box. And it's fantastic. And October, please feel free to join in with any feedback on that too.
Well, I think especially with, for so many years, because Don, he's 17 years in, and I'm embarrassed to say that I'm 20 years in. And Sherry says, how could we forget? You're right, Sherry. How could we forget? Those days are awful. But especially with the open notes mandate that has come out now, that is saying all clients have access to their notes, except for their psychotherapy notes. Now you can hold the psychotherapy notes from them, but the open notes mandate, that's a federal mandate. You have to take it just as seriously as HIPAA, because that's what it is. There wasn't a lot of research done prior to the open notes mandate, so definitely not in the mental health field, and none as far as no research was done as far as pediatrics and how that would affect them. So one of the things is, when you're thinking about how you're going to write your note, now you have to think about it not only I need to write it where I remember it, but now, and other clinicians can view it, but now I have to write it whereas the patient is going, your client is going to be reading this note at some point or has the ability to. And so in Icanotes, we use nothing but plain language, and we use none of the terms that will be offensive to the client, because it's difficult. Statistically, research data has shown that 20% of clients or patients do not agree with their mental health notes. All right. 2% it causes homicidal ideation. Okay.
Yes.
That's serious. And so you want to write those notes in a way that is not going to offend your client. There are also so many ways, there are only so many ways you can write that someone is grandiose and delusional without that upsetting them. But at the time, if they're really grandiose and delusional, that's what you have to put. And so we're very big on at Icanotes as far as making the assessments in plain language that are not offensive to your patients and clients, but will let you know the full story of what's going on. So that's one of the big things that we're focused on, especially with that mandate. I just slid on over to past psych history.
If I can add just a little bit to that, please. Just my own personal experience with that, I totally agree with what October's saying about this, and I think that that with open notes mandate and such, I would never want to intentionally try to hide anything or prevent my clients from seeing anything in their chart. But I have had situations where my clients where I have shared things with them, the documentation part, where they would say, "Oh my God, Don, you must have thought I was really bad off. You must have thought I was crazy. You must have thought I was this. You must have thought I was that." And that, I think, is the slippery slope here with this, in that, we are documenting that our clients present with limited judgment and insight. We are documenting that, disheveled appearance and malodorous and depressed affect and suicidal and experiencing psychotic symptoms like auditory and visual hallucinations, et cetera, et cetera. So, certainly our clients can take offense to some of that. And I really do feel like it could damage the therapeutic relationship. And it has in the past for me. So I don't know if you guys have experienced that or not, but that's definitely, I think, one of the very important considerations to what we're talking about here.
Absolutely. Absolutely. I can't agree more. Now, this is what we were showing here is the past psych history. And your client had some marijuana use since adolescence, and used just before she came into your office, right? That's used hours before. When did they use?
Sometimes, yes.
Right before, in the parking lot, sometimes, right? In the parking lot. And so, but this, the Icanotes past psych history just goes through, it talks about withdrawal, medication compliance, what kind of medications have they been on? Have they been assaultive to themselves or others? Where were their prior care settings? Were they hospitalized? Things like that. And
absolutely.
Then the medical history in Icanotes with this client, they're allergic to aspirin, and so they get hives from that. So in Icanotes, it's really easy to put in your allergies. They stay there on the chart as alert. And this particular client, Karen, she's been non-compliant, and we can write in the details there. And she is not currently taking medications, and you can see me typing in there. So with any of those yellow fields are typable. You don't have to use your own. What's in Icanotes is there for you to help you, especially if you're new, as kind of a guide to walk down through the questions, but you can also type as well. And then on the social and developmental history, this kind of and jump in at any time, Don. So, but I'm
absolutely
basically the social, this particular patient, Karen, she has no criminal justice issues. She does own her own home. It is in poor repair. She doesn't have leisure activities. She was married for 10 years. And you can see that that was chaotic with fights and separations. It's problematic. There is a divorce pending. As far as development, it was normal gestation, developmental history for her, but she had a 38-week pregnancy, prolonged labor, emergency delivery, C-section, a big baby. She had a big baby there, but no postpartum issues. And then when we go on to, because you can literally walk down the tabs, and that's what's so beautiful with Icanotes. So history of present illness, past psych history, medical history, it guides you all the way down. You can see here on this family history, the brother attempted suicide by overdose, sister has bipolar, and uncle is believed to have bipolar. And so some of our formatting is, is thought to have. Your patients or clients will say, I think they have, but they don't really know. So we make sure and put those in, also addressing maternal and paternal and those areas as well. And then we have the mental status exam in Notes that you can do very, very quickly, as far as it takes about 30 seconds just to go in and say that, they're sad, they're distracted, they're tense, mood is depressed, they're not psychotic, they deny homicidal ideas, they have normal cognition, what does their depression look like? What's their body posture? It's their attitude and facial expressions. So, and
Absolutely.
talking insight and judgment and fair, talking about anxiety being present and things like that. So it just kind of, it helps you roll through the mental status exam very, very quickly. So
I love the check boxes. The check boxes give me life. They just make me so happy. I love the check boxes, and they're so helpful and fantastic. And please, if I could throw in my 2 cents with the mental status exam, let's look at the MSE as like a brief snapshot with what's going on with the client at one particular moment in time, because I think that and October, I know you can agree with me, as we're working in the inpatient unit too, is that what one patient's mental status is one moment can certainly change an hour later. I think this is a brief snapshot in time about what's going on with this client, and I think that it's so very helpful. And also to recognize that this is also very subjective. This is your opinion on what's going on with your client. These type of things you are assessing and observing and making your observations and such. These are things that you don't ask your client. You don't necessarily ask your client whether or not they're disheveled. You don't ask your client whether or not they're malodorous or whatever, right? You don't ask them those type of things. Most of these things are very subjective observations that we make, and we click the appropriate box. No doubt. Check boxes, I'm a fan. It's great.
So now we do have, I just want to move on to our question. There are some questions. I would like people to ask questions now. I do have some questions for you. I've got one is, I need to know how to integrate the cultural formulation interview as well as the PHQ-9 and the ADHD and the CAGE, etc. So that's all in Notes. Every single patient's chart has forms and assessments in there. We constantly, every week, we're adding new forms and new assessments into the program. Someone did ask about Spanish. Yes, we do. We are adding some Spanish forms into the program. I also had, Dwayne says, I normally code my assessment as an intake. Should I use the biopsychosocial assessment instead? What are your thoughts on that, Don?
Well, I think that everybody refers to it as different things. I think if we're looking at intake, I mean, certainly I think with intake, there's also the assessment process with this too, is it not? So, I mean, I think we may refer to it as different things, but I think we're all doing the same thing at the end of the day.
That sounds good. Absolutely. Now we do have quite a few questions. Lee, if I can share your comment, you said, I saw disheveled on my own record. You were shocked and offended. I understand. I would have been too. Absolutely. And
absolutely. Absolutely. No, and that just perfectly highlights, and I thank you for saying that, because I think that perfectly highlights that this is a very slippery slope for us as clinicians, and that, yes, I am all about keeping it real. I'm all about, having those conversations. I think depending on your relationship with your client, that's so very important. I think they can maybe be more receptive to certain things depending on your therapeutic rapport with them. But I just think in general, I still get very nervous with them having full access to all of their records, including progress notes and such, because I think it runs the risk of potentially damaging the therapeutic relationship. I don't ever want to feel like, I don't want any of my clients to ever feel like I'm trying to hide anything from them, but I do want them to have a certain perspective that, hey, this was a particular moment in time for you too, and at that moment in time, you were struggling, and it's my responsibility as your therapist to record that and to acknowledge and to observe that. So it's still such a slippery slope. So thank you for validating that.
It is. Now we are getting a lot of questions. Is it multiple people have said, do you have a biopsychosocial template you can share with us? Is it possible to purchase the ICANOTES biopsychosocial assessment as a standalone? What I will tell you is a lot of people, I have some folks that work for companies, they're forced to use their EMRs, but they have an ICANOTES EMR as well, and they will take their notes and copy and paste and move them over, because documentation is so easy in ICANOTES. Even treatment plan documentation is very, very easy as well. So if you're doing your treatment plans, you can link them directly in. You can pick your short-term goals. We have lots of short-term goals, and they change depending on, so we just have a plethora of those. And I can throw some in here just to kind of see, so you can kind of see some of the things in here. And then for each intervention, we also have, as you can see over here on the top, there's short-term goals. So when I lock them in, then I have interventions over here, and they will change for each one. So we have a lot, and you can add your own with custom buttons. Now we don't have time to show you all that, but we are going to be giving you a gift, because you came to the webinar today, and we appreciate you so much, and you took your time. And so we are going to be sending you the assessment that is what we have in our patient portal. So we try to make it easy for clinicians at ICANOTES. If you can get people, all you have to do is get their email address, send them portal access. They can go on and fill out, it is a questionnaire about their family history, about their social history, about their past psych history, to save you a lot of that legwork. So if you want, it will populate that information directly into the assessment. All right, directly into the assessment. And so we're going to be sending that to you for everyone that attended today. So please don't worry about that. We will get that out to you. So, and there are, yes, we do have teletherapy. We have, that was one thing. As soon as the pandemic came out, we realized right away that we needed a telehealth platform. And so we have our own telehealth platform built into ICANOTES. So there it's very, very, very secure. So no problem. We thank you guys.
Thank you.
More questions? I want to make sure, because you guys, and one thing I have to say, I absolutely love, Lee, you are new into this field, and I love the fact that you got so much love in the chat. That just speaks to the wonderful people in here.
Absolutely.
So,
and a special shout out to I forget who it was, forgive me, but I did notice that there was a special shout out for Carl Rogers too. Carl Rogers is fantastic. Please check out, I know you guys have studied some of this stuff, but person-centered, and I mean, it's awesome. It is awesome.
Absolutely.
As are you guys. Certainly, I appreciate everyone's questions and attendance today. Y'all are doing such valuable, important work. I'm so very proud of each and every one of you. I know you're out there doing such great things, and times are really tough right now. I think it's important to acknowledge that. But I feel very confident that you are doing some wonderful work. So you guys, please keep it going, and please take good care of yourselves.
Absolutely. Absolutely. Thank y'all for joining us so much. We have one last
thank you
poll
so much
for you. And if you have any other questions, you can always email Dawn or me, but my email is October@ICANOTES, October, just at ICANOTES.com, and I'm happy to answer your questions, and we can field between Dawn and myself. And then, of course, we're giving a 30-day free trial of ICANOTES at tryiCANOTES.com. So
yes, indeed. Yes, indeed.
Oh, all righty. All right. Oh, people are like, how do I get the contact for Lee? This is great. It was great. We loved it as well. Thank you.
Yes,
Thank you guys so much.
Yes, indeed. Oh, wait. I'm sorry. I could talk to y'all all day, obviously. Denise, you met Carl Rogers. Oh, my God. And got his autograph. I'm so jealous. That is awesome. That is awesome. No doubt.
Love it.
Thank you for the kind words. You guys rock. Thank you so much. Take care of yourselves, please. And maybe I'll chat with you again someday soon.
Thank you, Dawn. Bye-bye.
Thanks. Bye-bye.